going to invite Dr. Shannon Shibata-Germanos to join us. We have some panelists as well, if they could come up to the stage for this session. The panelists for the next session, so Dr. Bita, yes, Dr. Mudoka, Dr. Omari.
Good morning, everybody. Everybody good? Yeah, we're ready? So I'm Dr. Shannon Shibata-Germanos, and I'm the head of global health at Proximie. And you'll hear more about Proximie in a little bit, but today I'm here to introduce two gentlemen first. You'll hear about the rest of the panelists, but I've worked around the world in politics and policy with kings, with presidents, with prime ministers, and I've negotiated settlements and deals around the world. And you don't need to know why today, but you need to understand that government and governance is so critical. As surgeons, you want to hole up in your OR and not think about politics and policy, maybe to complain about it. But the thing is that it's so important to cross that bridge so that the politicians who make the budget line items know who you are, what you do, and how you serve. And I think every single one of us in the audience, what we want most as citizens first is to know what people do to serve us when the cameras are off, when everything is quiet. Who are they really? Do they actually serve me, right? Because they work for you at the end of the day. And these men, Dr. Michael Moachiro, who's one of my closest friends, love you dearly, president of SSK, this is a guy who rolls up his sleeves and behind the scenes does the work. Governor, and yeah, the thing is that you might see the smiles and the laughs and the jokes, but you don't see what he does for all of you every day. I do. Governor Mutula Kilonzo Jr. I love this man dearly because I've traveled with him to countries and this man has flown economy. He never complained once. This man is the one who, when there is no camera, he's carrying the bags, my bags, he's moving the chairs, he's getting things done. He goes to the front lines to see the patients in your ORs because he genuinely cares. No one's taking a picture. That is what we want from our leaders. So I am hugely honored today to introduce Dr. Michael Moachiro and this esteemed panel who are going to tell you about how to cross the bridge between surgery and governance. Welcome.
Thank you. Yes, a round of applause for her. She goes to sit down. So I want us to have an honest discussion about issues related to surgery. And so just to introduce Governor, these gentlemen and ladies sitting here are the surgical workforce for the county. Counties, not counties, because Kenya has 47 counties. But the Surgical Society of Kenya brings together all of the surgeons across the different specialties, and most of our members work in the different parts of the country, in the county referral hospitals, in the national hospitals, private hospitals, faith-based facilities, and they are in the trenches every day. And so we as SSK have been committed to providing surgical care excellence and training, and looking at the questions of how do we improve and provide for capacity for the next generation and for the Mwananchi at large. And so my job is, I'm the current president of the society, and with me here is a team of these panelists represent the surgeons in the different parts. So Dr. Bita is based in Kisumu at JOTRH. Dr. Abdallah is based right here at Coast General, and Dr. Mudoka is based, of course, home ground, Makueni County. And so neurosurgery, MIS, and general surgery. So we want to have some discussions. So over the past decade, counties have built real capacity in surgical services. The theaters, the specialists, the referral systems. And in some counties, genuine innovative financing and digital infrastructure has been put into place as well. Yet, whether a patient reaches specialized surgical care on time still depends too much on where they live. And we had some of these discussions yesterday. So before we start this panel discussion, I want to say something to all of us in this room, because it is the reason we're having this discussion actually. So every one of us trained in medicine, but not in politics. In fact, yesterday we said, even not in business. We are learning some of these things as we go along. We train to operate, to save lives, to heal. But the truth is that we can deliver, and what our patients can access is shaped a lot by policy and political decisions, and as it is by the clinical skill that we have. The budget cycles, the procurement, the workforce issues, the priorities set by the CECM offices and at the Council of Governors. So when the surgical profession is not at these tables, then we are not able to participate in those discussions. So the 5 voices on this stage will be helping to shape and shift some of the discussions. So for Dr. Mudhoka, directly working with the Makueni County, Dr. Omari Abdallah at Coast General, and he's been doing a lot of work with Proximi here. Actually, all of them have been doing work with Proximi. Dr. Bita at JOTRH will provide some evidence based on what they've been doing. And then for Governor Kilonzo, who is now Amicus Curiae of Surgical Society of Kenya, will be sharing his voice on what he's been doing. And so we are fortunate also, where is Professor Odula? Yes, he is our moderator on the floor, hereby appointed. If there are questions to collect from the floor, he will collect them as we go along. So don't sit very far. Over here, yes. So for the audience, please think about these discussions, and we will be asking you to participate. So I'd like us to jump straight into it. And I think one of the things we are highlighting is we are looking into making minimally minimal access surgery as a thing that we are championing across the counties and in Kenya. So Dr. Mudhoka, you know, you are in the trenches in Makueni. You have what many surgeons in Kenya would describe as an unusually direct working relationship with your boss, who is actually sitting right next to you. He has actually come to watch you crack skulls open, okay? Using the drill and screws and all of those things. So he understands what you do. And what is happening every day in your department, like he can watch you on Proximi and say, yes, this is what is going on. So 2 questions. What had to happen on your side to build this kind of relationship? And what would make it easier for governors and other CECMs to replicate what you do?
Thank you very much. Good morning, esteemed colleagues. Which some of you have not seen for years. It's great to be here. I'm also seeing my teachers. It's amazing to be in SSK. I've not been in quite a while because we keep ourselves in our EANS and our neurosurgery conferences. Thank you very much for inviting us and for highlighting what we are about to discuss. Straight to the point. What had to happen for this relationship to grow? When I was I got the opportunity to be a neurosurgeon in Makueni. I'd started a bit, I'd tried to start a unit. I was the first neurosurgeon in Meru before that, and I'd seen a bit of the challenges of setting up a unit, and so I was uniquely placed when I was sent to Makueni. I already knew exactly what I wanted and how things needed to work for me to be effective in Makueni. And one of the things I noticed is that if you do not attach yourself or become just doggedly determined to get the administration on your side, you will not grow, because they're the ones who will be in the budgeting. They're the ones who will decide whether you will get what you're asking for or not. Also, the fact that neurosurgery was new to Makueni means that I needed to demystify it to everyone, literally. So from the moment you get into theater, the theater nurses are part of your class. Everyone, you have to talk to everyone about what you're doing. And so it made me a bit less, actually it made me more approachable. So I was more willing to discuss and to simplify what everyone was thinking was complicated. And so one of the opportunities I had was to get his contact, because he has an open door policy. As the relationship has to be two-way. He has an open door policy, and his number was somewhere circulating in the county. So I got it, and I had it on my phone. And so after I tried to approach the hospital administration on some of the things I wanted, I realized that was not working. And you see, it's not working because patients are coming, they've been told, sorry, I'm rushing. There was a camp that we did before, and it showed us the burden of what neurosurgery was present, or the burden of neurosurgery that was present in Makueni County. I think that camp we saw 800 patients in a week, right? So we had done a very good camp, and he was able to see the burden, and so he knew this conversation was going to come. He was just waiting for it to come up at some point. And so after I realized that things were going a bit slow in the county to get the things that I needed for my patients, I had to take the bold step of looking for him directly. I looked for him for about 2-3 weeks, very busy. I called, he doesn't know my number, and I'm not part of the high county administration, the county administration that can directly just talk to the governor. So I had to take a bit of time. I called a few times, then I realized that's not working, so I texted him. And actually, he read his text and he responded to the text. He told me that I asked him on a Friday, he told me I could meet him on a Monday morning at 7 a.m. And I was there. So when I arrived, I didn't meet a whole panel, I met only him. And we sat down and discussed what I was thinking about Makueni and what I wanted.
I've seen it myself. When the Brain Tumor, or the Tumor Society, I don't know what they call it, Brain Tumor Association, Kenya, came in, I was patients coming from, because we had community, we had patients coming all the way from Mombasa, Kisumu, Kiambu, Machakos, some who had suffered for years. And I thought if we could have Dr. and we got Dr. Muthoka in. When the surgical came to Makueni to do some of his surgeries, we were overwhelmed. We had to lock gates at some point because we couldn't cope. And this is a good team, and I want to use this opportunity to thank you, because if I don't do so, then I'll be a very ungodly person, because they even brought surgeons from East Africa. Because of our usual bureaucracy, some of them were unable to perform surgeries because this, about the licensing requirements. But what made this easier? Shannon here brought technology to Makueni where I could just sit in a room and watch the surgeries going on. So this good gentleman here, when he was doing some of the surgeries, really brought this home. I didn't know that you can just drill somebody's head, something that looks like you are doing carpentry. And some juice and something it's called jungle juice. Jungle juice. Yes. And then there was, what is this wax that he was putting?
Bone wax.
Bone wax. So he drills, puts bone wax. Tells me, wait, I'm coming back to it. He goes to another one, drills, puts bone wax. And then goes to the other one, drills, puts bone wax. And then he says there's a better tool. So I understood that it tells me that there's an easier tool that can bore faster. But then he was just doing this. I watched this gentleman do a surgery on a lady who I met when I was in the Senate, who had very beautiful scarves. So we wondered, why does this lady have such beautiful scarves? Whether it is raining, in the middle of the heat, she had a goiter, big one. And Professor Abdullah did the surgery and I watched it. And he removed something that looked like a tennis ball or bigger. And this lady healed. Now she walks around, everything she wears is now low neck. She makes sure that you can see her neck. Sometime during a public function, when we announced that this team was coming, and I must say this because this was one of the most touching moments, before I finish with what Dr. Muthoka did, because that one was even more personal. I met a lady who was brought to me after a public function, and I was told, this lady, a very young lady, by the way, but when you look at her, she was looking very old. She had a growth that was running from the back of her shoulder all the way to the front. And she was wearing a blouse which could not fit. She looked even to some extent that she was not okay. This good gentleman and ladies removed a 5-kilo lymphoma. 5 kilos. When I saw the picture of the lymphoma itself, I nearly fell off my seat. And it was removed. This lady had this growth for 8 years. She left school when she was 13. She was 21 at the time. And she had given up on life. When I met her about a month later, she had cut her hair. She was wearing some nice torn jeans. She was walking around the market very happy. Life came back. I had 2 instances with Dr. Mudhoka, and allow me to finish so that in terms of assisting your work, the basic realities have come to my desk myself. There was this young lady, 2 instances, there are many, but actually 3 instances. First instance, I had a student I'd educated throughout high school. She was now in university. I was called. The family was in distress. She had been told she had a growth in her head and she needed surgery. So I called this gentleman. I said, this case, you'd better look at this case before you decide whether you want to do surgery. Guess what? This gentleman ended up not doing the surgery, and the girl is healed. Because after doing the numerous scans and tests, he discovered there was no reason to do surgery. The second instance was a young man who was attacked. I come from a place called Mboni. Mboni Hills is possibly the highest, is higher than Nairobi. So this young man was accosted by 4 people at night, or 5, beaten up senseless and thrown off the road into a ditch. He was lucky that in the process of throwing him, he landed on trees. It's highly forested. So he lay there from night, the whole night, and Mboni is so cold. The temperature at night is easily 6-7 degrees at night, every day. He lay there the whole night, was discovered the following morning by a husband about 11 a.m. He couldn't move. He was brought to the hospital, and by the time I was told, when I was in a meeting, he was ready. The hospital had not figured what to do with him. He had bed sores, actually. So I asked Dr. Mudhoka to check the patient. He operated on that young man, and the young man is now in good health. He didn't die. So a few days in January, this gentleman sends me pictures. And let me tell you the realities, because he is able to send me pictures to determine that I need something done. He sent me pictures of 2 children. How old were they? Days old, yes. They had what we call hydrocephalus. So I've learned, by the way, don't think you can confuse me with your terms. So he told me, I have these 2 patients, in the hydrocephalus, and I need to do surgeries immediately. And I need 1, 2, 3 things done quickly. And I sorted what he needed to do administratively so that he could do, and I went to see the patients. And he tells me now that these 2 children are in good health. So the reality of the matter is that part of the problems with us, and I'm talking about us collectively as the people who sit in leadership, is if we don't understand the work you do. It's because we are not in theater to understand you are there for 6-7 hours. You need tools, you need reagents, you need things done that would save a life. So the work that the Surgical Society has done has enabled us, has also trained, because by the time the professor and team and Mwachiro were in Makueni, we were not doing laparoscopic surgeries. By the time they left, Kefa Ombati, one of our consultants, was...
Yes, he's here actually.
Where is Kefa?
Dr. Ombati?
Dr. Ombati.
Yes.
Oh, there he is.
Yes.
This gentleman was nearly biblically born again. And I went recently when we got some equipment, and it is Dr. Ombati was taking me through the equipment in the theater. And this guy tried to confuse me with something called a bipolar. So she said, bipolar, monopolar. So when Dr. Ombati was explaining the bipolar, which I could see, not on screen like I did when we were doing the Proximate technology, I was pleased to see that, in fact, if you guys understand games, I was telling the team this morning that Kefa was talking about, Dr. Ombati was talking about the bipolar, the way I would talk about, a young child would talk about a PS5. He was talking about those gadgets. And that's the useful part. Now, let me finish by saying this. we had yet another camp for obstetric fistula. Now, I was a little disturbed to learn that we have 11 of them in the whole country. So when we had this camp, we had about 300 women. I met this lady who had grade, actually, and had had obstetric fistula for 19 years. She was from either Kiambu or Nairobi. So the technology that Proximi brought to Makwani will enable our surgeon, Dr. Mbidi, who I can forfeit my salary for her, to train, because if we only have 11 surgeons in the whole country, you can imagine how long it will take to have 50. So without the technology that that has been piloted and is continuing, and I'm happy that people have picked it up and counties have picked it up, it will be impossible to deal with obstetric fistula. And yet, ideally, there's no reason why a woman should suffer obstetric fistula simply because she had obstructed labor. And I thought that if that lady who came and heard about this fistula camp and has suffered for 19 years, I can imagine how many more women in the country are wearing diapers so many days after they have delivered their children. Thank you.
Makofi kwake tafadhali. So Governor, I wanted to say something when you mentioned about Dr. Ombati, because that's a good transition.
Yes.
You've brought up the issue of laparoscopy.
Yes.
And one of the areas we are now focusing as a society is ensuring laparoscopy happens, everywhere in the country. It's actually one of our flagship campaigns now. And I think to help underscore that, Dr. Ombati is a resident surgeon.
Yes.
Maybe Dr. Omari here can share from his experience, and then we'll tie it to what you've seen in your county for laparoscopy services provision. So Dr. Omari, do you want to tell us about your experience in Coast General, how it has been with doing the laparoscopy services you were part of, using Proximi to transmit the cases the same way they did in Makueni from Coast General out to the US and to the DEVCON conference last time that we were in Homa Bay. So how has that been for you?
Thank you, Dr. Machiro. I'm happy to be here, and thank you for the invitation. So basically, laparoscopy is, I think everybody in this room understands what it is, but it's where we do surgery through small incisions, and this helps to reduce the amount of trauma or injury we make to patients, and it reduces the hospital stay of the patients. It improves in terms of pain management for the patient. So it's a form of surgery that we are currently all getting into in different aspects of surgery. And this is not only in general surgery, but also in other subspecialties of surgery, neurosurgery, ENT, obstetric gynecology. Now, this has been adopted in Coast General, Teaching and Referral Hospital here in Mombasa, and it's part of our core departments of surgery where we do minimal access surgery. And this also includes things like endoscopy as well. Now, where Proximi comes in as a technology, it's something that now helps us in training and mentoring and transmitting the same surgeries and sharing it with colleagues. For instance, if you're doing a surgery, like my colleague Dr. Mayabi in Nairobi is doing a surgery, we are able to dial into his surgery, learn from what he's teaching, from how he does, the steps he takes in every surgery, and it can be used as a platform, not only to teach it, but even to mentor colleagues who do the same surgeries. Secondly, it goes down also into surgical education, because we are in institutions which are teaching residents. And it really helps with the residents. If a resident in Makueni, he can dial in a surgery that is in Mombasa, and they are able to see exactly what the surgeon who's operating is seeing. So you can imagine the image is one-on-one. Whatever I am seeing, they are seeing. And because the image is transmitted laparoscopically on a screen and it's enlarged, it's very easy to learn, and it's a two-way platform where we can actually discuss the case as we are doing the surgery. So it's really gone a long way in enhancing how we share surgeries, share techniques, share experiences, and even just enlarge the whole capacity of this kind of surgeries in the county.
Thank you. And I'm going to ask Dr. Bitter to provide some numbers, because when we engage with the governor, we want to say, this is what is happening in our county. So to provide a backdrop to this, the next question which is coming to you is from Dr. Bitter's experience. You know, at JOTRH, you actually have been looking at what minimal access surgery, laparoscopy, and endoscopy actually deliver in length, practice outcomes, and cost savings to buy the equipment and to train. Drawing on JOTRH, making a case for actually doing a surgical data repository.
Was moved from a county hospital to a parastatal hospital. Last week we had cardiothoracic surgery. We had a colleague in the room, Dr. Dare, doing a cholecystectomy. So we have not reached CPGH levels where they have, I'm assuming they're doing 50, 60 a month in terms of minimal invasive. We are still at the level where we're doing 3, 4 a week, okay? But what I really want to emphasize on is the economic part of it, yeah? And I'll do the 2 cases that were done last week. Dr. Day is in the room, yeah? The cardiothoracics are not here. For a video-assisted thoracic surgery, yeah? The procedure with the laparoscopy, with the thoracoscopy, is 1 hour, max. The patient stays in...
Thoracoscopy, Governor...
is laparoscopy, but for the chest.
Yes.
For the chest.
We are putting
yes.
a hole in the chest, yes. And a camera in the
Thorax,
chest,
yes. So the same thing that you see Ombati and Mudoka doing, but now we have guys who do it on the chest. So the procedure was 1 hour, okay? The patient stays in the ward 2 days, 3 days, okay? The rates that Professor Jaoko has and his team at BTAP has given for thoracoscopy, video-assisted thoracoscopy and lobectomy, is 590,000. You have the option of doing this the open way, making a long incision, opening a third of the chest and doing all those things. The patient will be in the ward for a week. There's a higher chance of getting infection. The pain is poorer controlled, yeah? And for that, the rate given, I think, is it 140 or 240? Something like that. It is less than half. Now, if your patient has SHA, like the one they had last week had SHA, and the whole 590 is paid for a 3-day stay vis-a-vis a 1 week plus stay, the maths does not add up. It simply doesn't add up, okay? The equipment that you'll need, the tower that Gianni was sharing, yeah, is the same that the cardios will use, is the same that Dr. Marwa here will use, is the same that Dr. Dea here will use. So you have people of different specialities coming in, sometimes even on the same day, to do different procedures, and in a month, in 2 months, you recouped the cost of the equipment. It doesn't make sense not to invest in it, okay? JOTRH is in the process now of getting a new endoscopy tower. They had one that had lasted some years. Of course, it ages and everything, and I know Dr. Dedan here was part of the team, and Dr. Dare in bringing up the new tower. Because moving to minimally access surgery is a no-brainer. Is a no-brainer. We were sharing with some of the older colleagues. You know, nowadays I'm called an old surgeon. I don't know. I'm only 50. But the transition is that way. And as Omar was saying, some of the centers like JOTRH are training the next generation of surgeons. It would be very unfair if they'd come out not being able to do that. Okay? For me, Mike, and the older guys, we really had to go out to look for those trainings. But I think for Omar and Mudoka, that had to be part of their training. But the big thing is just in numbers. If you have an endoscopy tower that is doing 700, 800 cases a year in a public hospital, yeah, and you're charging 5,000 for the endoscopy, even if the tower was 3 million, yeah, the maths again is clearly out there. So we just need to be able to send our case out to the governance, okay? If you are in Makueni or you're in Kisumu, you are lucky because you find that the governance structure is really in touch with the health sector. We have a CEC who is a surgical oncologist, gynae oncologist. We have a chief officer for the county who is a surgeon. Yeah. So it gets a little easier when that happens. But I think we as surgeons really have to go out to share with the governance what is happening. And one of the easiest way to do it is to share data, okay? Be able to have your data and to share. You see the simple maths that I've shared here, yeah? I'm sure that if a thoracic surgeon goes to Makueni and tells them, Mutula Kilonzo, there's this thoracoscope and it's costing 800,000, the rest I'll use what the guys are using. His county director is there, he'll tell him, "Well, I need this thing tomorrow." Yes, it doesn't make sense, yeah. So we have to go out to share the data on how this makes economic sense. Kisumu is easier because the structure was good. We had people who had the data and were sharing it. So there's a system for reporting it. Again, a Kisumu example. There are 4 surgeons here from Kisumu, yeah, who every morning in their phones know how many cases were done yesterday. True, guys. Every morning in their phones. Every month, there's data shared, including broken down to cases done by individual surgeons. So, you know, as you grow older and you're doing less and there are junior people doing under you, so sometimes you get perturbed when it's put there and it's said, Dr. Bita did 2 cases in March. Okay? Yes. But it is data that once you share out and you come and say, we need this support, it is easy to defend your case. So the surgeons have to go out and collect this data and find a structure by which they share it with the counties.
Thank you. Thank you very much. Let's give him a round of applause. So Governor, I come back to you now. We've had the case, you know, the data, the numbers. And so I want to ask this question. Putting this together, so Dr. Omari has given us an example of what minimal access surgery changes for patients. You know, the hospital stays when you have laparoscopy, thoracoscopy versus open surgery. Dr. Bita has underscored that. Again, has given us the numbers and what it looks like from an economic perspective. So the question I have, and actually it's 2 questions as we begin to come to the towards the tail part of this. So if SSK brought you a costed document, you know, like we say all of the counties here have said we would need X amount to buy 1 tower, or in your county they say we need X amount to invest in the following equipment. And so we gave you a minimally access surgery capacity plan with costing for 1 county referral hospital per region that we've equipped and for the training that goes with it. And then we say this is the model for implementation. And we are now asking Council of Governors to adopt this. So 2 questions. The first one is, what would that look like from your perspective if you brought this model? And secondly, from your seat as the governor, what are the things we can do as surgeons, and some of it has been said, to help fast track these processes? Because sometimes we don't understand from the governance side what you would need to make it actually happen. Okay. Because you have them here, and when we go home, we can write you the report on Monday.
Thank you. In Makueni, it will be, I would suspend something that we are going to do so that we can get the equipment in, because I realize what that does. We are serving in Makueni possibly 4 counties. You have our 2 neighbors, Machakos, Kitui, Kajiado, and Taita Taveta at the first instance. and a lot of the people who are traveling along Mombasa Road, because we are covering nearly 200 kilometers, the largest in the country. So I would be the first one to take it in, because I understand what that means. And I have, maybe on hindsight, thought that I would make Makueni a tourism site for health, so that people just come. That's why I invited Dr. Chris Musau, the Surgical Society, who came with the Rotary, where I've been a member for the last 25 years. What all of you need to do, and particularly where you sit as president, is to now engage county leadership, so that then you cushion your members, so that your members are not problem about us. And I say, speaking on behalf of leadership, is that we have created a bureaucracy that is supposed to help, but it doesn't help. When I was dealing with Dr. Mudhoka, I changed the pyramid from bottom up to top bottom. So it starts at the top going the other way around, because it's easier and faster. Now, the society must then understand the budget cycles, so that you don't leave it to the finance team to do budgeting, planning. Because I was told the surgeons don't attend the meetings. When it comes to budget, they don't attend the meetings. So nobody sits in the meeting where the 1+1 is being done, because you think that's not my work. But the person sitting at the top does also understand what is happening and will skip you when it comes to your equipment, your reagents, etc., etc. You're now in the budget cycle, currently. So budget cycles for counties means on 30th of April, the executive must submit the budget. By 30th of June, the county assembly must pass the budget. At the national level, you have a budget policy statement that is tabled in Parliament on 15th of April, must be passed by 15th of February, must be passed by 20th of February. It has timelines. So don't leave your work to minimal invasive and cutting and reagents. Also get a team in your executive to understand budget cycles. Once you understand the budget cycles, it becomes easier. Now, the other plug, because you have a good gentleman here from COG, and is to then find the formula through the Committee of Health and Budget to have an entry point. You can still use me for now, but we need to have this discussion at a very high level. It's not that my colleagues are not responsive. I must say that some of the things that you do, they don't understand. They don't know you. And there's a reason. You look very different when you are ordinary people, because half the time you wear clothes, masks, and things. So when you step out of, and I want to confess that when one of my colleagues had a problem, Senator Kabaka, and I called Dr. Chris, and I went, when he was going to surgery, he looked different from the time he came out. When he came out, I was nearly shocked. Who is this? And that was Dr. Chris Musau. So, could you please, while you're in this state, means not like,
While you're in the normal state.
yeah, yeah. Now that you look approachable, and you just look like normal people, sit then with the leadership. Sit with leadership and explain to them what needs to be done, because some of the things that I have seen are very easy to achieve. And we can scale it, because everybody is looking out for what is working. And I say this about counties. We don't need 47 successes. We just need 2, 3 running. When I started the advocacy on heat-stable carbetazine, I was the only one talking. By the time I finished, KEMSA put heat-stable carbetazine into the essential medical list. Next, Muranga was running. Next, the others were running. Next, KEMSA was procuring. So that if we can get the Surgical Society to push even Mombasa, the chair is in Mombasa, Governor Abdul Swamad, run that one. Go to Tharaka-Nithi, where the former chair sits, run that one. Come to Makueni, we are prepared to pilot anything, including piloting. You'll be shocked.
And
this will run quickly. We must, and somebody mentioned, even the press mentioned, and I want to tell you, good people, that when you call meetings like these ones, and you sit and discuss, the language you use is for yourselves. It's like lawyers. if I sit here like a lawyer and start talking about something called nemo dat quod non habet, it's Latin, but it's a simple thing that you cannot transfer better title than you have. So if you change these acronyms and sentences that mean so many things and are so confusing, and make it ordinary, bring the leadership here, explain to them minimal invasive surgery, and not a tower, because when you say laparoscopic tower, you know, for a lot of people it becomes very complex, that it will take short time, people's getting there, and for the women, there will be no scars. They will still look beautiful, even after surgery. The minute this becomes simple, then it becomes easier for even our leaders to understand. Some of the times, and I say so because I've defended doctors. When they were arrested, I raised hell with the government. The minister told me off, and I told him off even some more. It's because your work is misunderstood, the language is misunderstood, the troubles are misunderstood. That's why you end up half the time. I've not seen surgeons on the street, but half the time people saying haki yetu with mabango. After that, the conversation disappears. Can we have conversations with surgeons, with leaders, when you don't have a protest, when you're not making a demand, but when we are engaging in a way that is supposed to help and make your life easier? We are supposed to do even advocacy to make sure that, and let me give you a good example of Proximi. They got us technology. And we came to Mombasa and we went back with it one time. But let me talk about the cost. By the time we got the technology that Proximi was bringing to Makueni, the tax was more than the cost of the equipment. But since Shannon wanted to deliver it to Makueni, she brought it. So we have got to have a conversation with national government and tell them they are joking. The tractors don't save lives. The work you do saves lives. So that we can ensure that we are not sending. We has produced the best doctors, best surgeons, and nobody.
You have to be politically correct.
Moran of the burning spear. See, most outstanding head surgery. It doesn't happen.
So, Governor, on that note, because that's a good segue, I would like to ask if there are Mike, are there some questions? And while you're looking for questions,
sir. Thank you very much, the panel. But currently, I'm working for JCOT. If you realize, liberally, and it's actually a working institution. Now, my question to you go in terms of your funding model for the hospitals. How have you maintained the good practice in your level 4 and level 3 hospitals? Because when I go there, and this is not political, I found their medications and their people on site. And number 2 is the issue of the HR. How are you addressing your HR gaps? And the last time I went to Makueni, it was at 4:30 in the evening, Makueni County Referral Hospital. And I was happy to meet staffs at their place of work. What are the kind of motivations you give to your staff to make them be that responsible, especially in this current setup in the country? Thank you.
so Governor, maybe we take one more, then you can combine them. Is there another question?
Another question. Dedan is next.
JTRH. And I've worked as the Director of Clinical Services at JTRH. And there are some things that I've learned that I think we need to remember. The people who control finances, some of them may not understand what we are doing. But us, the surgeons, also forget and assume that these people know. And the way we had to fight, and as I was talking to my team on the ground, these surgeons, if require. Some of them will cross the other side to the private hospital. So it is a kind of engagement. I think as Surgical Society of Kenya, encourage our membership to get involved, to be focused and try to push this other side. This other side are very, and I was telling my team the other day that when you have the leadership and non-medics, they are actually to work with, because sometimes they don't know, but when you give them the facts and the evidence, they are able to move fast, and I think that is a very good kind of engagement we need.
Thank you. So, Governor.
Thank you, Dodent.
Yes.
Governor.
Let me start with human resource for health. It's a big issue. It's a big issue countrywide. Shortages are huge, and from a legal standpoint, I'm not quite sure whether we got it right. I've mentioned this at the high levels. So when you construct a hospital or dispensary, that's development. When you hire a nurse, becomes recurrent. Correct? But yet, the facility can't run without the nurse. So I've told the control of budget and the people who are talking about wage bill that I don't understand whether we figure out what we are doing. When we say promote doctors, upgrade them to their correct job groups, we are fighting all over the place. I remember that when the clinical officers' guidelines were done, I had problems with the Council of Governors, and I told them, you might fight, but this is going to become law very quickly. So I made sure that I implemented it, even before there were approvals. That's the reason you do not have strikes in Makueni. When everybody's on strike, you force our clinical officers and nurses to go on strike when they don't want to go on strike, because they have no issues. Because we have addressed their concerns in terms of motivating them, promotion, etc., etc., and we've set aside budgets. And we make sure that the HR component is taken care of. Commodities is also a big problem. They run out quickly. But in terms of ring fencing budgets, Makueni was doing FIF before FIF became law. So we were ring fencing budgets in advance, even before FIF came law. So by the time the Facility Improvement Fund became law, we were just enjoying. There was preaching to acquire. We were already in it. And it's something that I found Professor Kibwana had already put in place. And these teams were very keen in ensuring that we ring fence the budgets. So we have hospitals and dispensaries, level 4s, running semi-autonomously. Semi-autonomously. So the CC Finance knows that you don't sweep revenue at the time and even now. And of course, I have a big passion of ensuring that we have partners. The partners in health are more than the partners in everything else. All they need is an understanding that when the resources come, they'll be properly utilized and they will get an account. That's part of it. And that's how we have managed to motivate our staff to ensure that when they're in office, they know that we care. I have a rewards and sanctions guidelines of ensuring that those who work well get recognition, and those who do well get their place on top of the food chain. That's what happens. And I agree with about matters, budgets, and as mentioned, because it's easier for a county to start purchasing cars and purchase ambulances. It's easier for them to buy big cars, not ambulances. It's easier to go and do big projects and not buy equipment, because they really don't understand. So it's important that the issues that you're dealing with are demystified in budgets. Whether it's reagents, if it's surgical care, let it have separate budget lines, separate cabinet papers. What Mudhoka is doing comes separately. What the reagents lab comes separately. HR comes separately, so that we don't talk about budgets globally. Because when you talk about budgets globally, when I say health is taking 38 to 40% of the budget, 50 of which is HR, the rest of the things that Dr. Mudhoka, Dr. Ombati are doing disappear in the woodwork. When we separate them, it becomes easier. And if we facilitate, like you're mentioning, you do it the reverse. When you facilitate them with the equipment, then you increase their OSR. By increasing their OSR, you make them a little more independent, because I have given the liberty to our dispensaries and facilities to even do locums and to hire staff. 161 of my facilities out of 242 have one nurse. And the day I increase one, Senator Kajwang comes for my neck about something called wage bill. What are you doing? What is the problem with Makueni? And yet it's just one extra nurse. So that sort of functional independence, a semi-autonomous independence and understanding, is what has helped us in terms of making sure that facilities can buy their medicine quickly. And we have a policy, and I've bothered to get into the details. When facilities says, or the public says we don't have medicine, they are not talking about gloves. They are talking about paracetamol for children. They are talking about that antibiotic that I like. What is it called? Amoxicillin tablets. Amoxicillin tablets have run out. The paracetamols have run out. So in terms of essential medical list, we have even done a drawdown. So that we say, push up this, push up this. I now know that hypertension is highest in Nyeri and Makueni. So when you are purchasing commodities, we purchase commodities with that in mind, so that we can take care of the disease burdens. It's not enough. It will never be enough. But we must achieve the 80-20 rule. Thank you.
Thank you. So a round of applause for that. I think we'll take one more question, and I think there's one more at the back. So those two together. Yep.
Dr. Mulongo here. First of all, I want to say that we need to know the God that Makueni people pray to. Because for them to have Prof, then followed by Governor Mutula here, then we need to know that. They need to tell us. My question is simple. What posterity measures have you put, Governor, so that tomorrow when your 1 term or 2 term ends, the Makueni people don't miss you? The things you started continue. Because we've seen that, especially when there's a change of governorship, you find that, oh, Mulongo as the governor started building this hospital. Me, I've come in as a new person. That one is not my project. They leave it. So what posterity measures have you put? Thank you.
And then the second question, it was, I think, Karan. So we combine them, and then we can begin to now wrap up all these good discussions we've been having.
Thank you. Karan Gandhi. I'm a liver and pancreatic surgeon, also an avid minimally invasive surgeon. It's a bit of a complex question that I want to ask, but in terms of capacity building and budget allocation, how should we as a society approach it? I'm going to explain where my question is coming from. How should we approach it? Because surgery is extremely vast, and you know we have different priorities based on what our specialty is. The neurosurgeons would want complex neuronavigation systems. They would want an ultrasonic dissector to do some certain work. As a liver surgeon, I want to work towards eventually liver transplantation in Kenya. As institutions or as a society, when we are approaching government with our vision or our budgets to say that this is where we need money, how should we think about it, or how should we go about it in terms of prioritizing? Because certain things are extremely expensive and other things are within reach if you think about what the cost is. However, if you look at it conversely, if I can set up a unit to be capable of doing liver transplantation, then automatically that unit would be able to handle probably everything else. It'll be able to handle all laparoscopy, it'll be able to handle all sort of complications, interventional radiology, etc. So should we start small and work our way towards bigger things, or should we just aim big, and in that sort of approach, we equip the center to be able to handle everything?
Thank you. Let me start with the last question.
Yeah, go ahead.
It's just a question, and I think good doctor from Jaramogi explained numbers, the numbers game and the figures. So what might appear as a very complex thing and very expensive at the first instance, ideally should be matched with the figures he was talking about, 800 patients paying X, and then the return is Y for a period of time. And let me explain why this is important. The government started something called County Integrated Industrial Parks in 2022. The counties were supposed to put 250 million. National government was supposed to put 250 million. It's 500. It's now 2026. None is complete. But counties have put resources. What if they were buying a laparoscopic tower, which would have treated, possibly, if you use the mathematics Dr. Bitter is talking about, how many patients would have been treated, how much money would that have been, and what would be a return? Now, there's something that all politicians like, and I used it when we were doing the advocacy for how many women are dying for postpartum hemorrhage. And when I mentioned the figures, their eyes go wide open. I said 10 women are dying every day in Kenya because of postpartum hemorrhage and related complications that are preeclampsia, anemia, others. They are more than the accidents happening on the roads today. When I was in the Senate, and I spent 10 years in the Senate, we never discussed those numbers because those numbers never came. No, they never came up. And if you were to tell the politicians who love women when they are dancing with them that 10 are dying, and I told, it's true. I accosted the cabinet secretary about Garissa. When I got the numbers, I told him your hospital at home had 18 deaths. When I say that you should facilitate SHA for level 2 and level 3, I am damn serious. Because you are the minister in charge of health. Do you know these figures? And a lot of action took place. So put the human part of it. I mentioned this because I got it from a book and I pretend I know it so much. There's a book called More Human by Steve Hilton. Steve Hilton was the advisor to David Cameron. And when they left office and he was removed as Prime Minister, he wrote a book written More Human. And he said one of the problems about government, and I'm going to tell you surgeons, it's also problems with surgeons, is that governments are complex, governments are inhuman, governments are big monsters. The only way to change what you're doing and what I'm doing is make governments more human. So translate to the human component of the money. When you speak about the government of Kenya can easily sign a deal to do a 5 billion road, dual carriage, so that the people who are going to Nakuru don't get stuck in traffic. Correct? They are prepared to sign a deal quickly for a dual carriage to Rironi. How fast can they do, if you tell them about the sort of equipment you require, the cost is 10 times or 100 times less than what we are prepared to make sure that people are driving comfortably, going to Nakuru, Mau Summit, Nini, and the roads from Mogashe, Isiolo. You know, that sort of discussion is very palatable. Not what Dr. Omari is doing. that you can have surgeries one day out. You can do 300 and you make sure that the cost is reduced. If some of these conversations can go to figures, that it takes X, and the figures he mentioned are important, from 590 to 140, and then one day that person goes home. It's like the discussion about fuel. The minute fuel reduced by 9 shillings, there was a relief, yet it had gone up by 200. Correct? Because people felt what you people call placebo effect. Isn't that what you said? It's called placebo effect. So I'm not guessing. It was like a placebo effect, yes. Something that you are given that is not real. So let's translate budgets to human beings, to people, to children. When I attend this morning I did an MP DSR meeting, we do it every Thursday. I told them, this is not a money queen we are discussing. This is a human being. So put yourself in the shoes of that human being when you're discussing some of these cases and the things that went wrong. And I think that is where we need to change the conversation. Once we change the conversation, the cost you're talking about becomes easier to explain to county governments. County governments are entities in perpetuity and can enter into contracts to do 5-year programs. We did MES for, how long was MES? MES was
almost 10 years.
10 years. We did MES for 10 years. And we can do the same for equipment for 5 years. And you can break it down to successive budgets so that then it becomes easier to get some of this equipment. And I'm happy to hear about what you're doing on liver. Those conversations are the ones that we should talk about. Because we are having a new disease burden. And I'm told it's caused because of aflatoxin, liver cancer. It's something that we have discovered is now happening and is not being discussed. Thank you.
Thank you. So I would like to now wrap up this discussion.
Posterity. Oh yeah, posterity.
Posterity measures, yes. There was a question
Now,
about, yes.
Makueni has a very interesting government structure. And this was created by Prof. So when you get into office like I did, you won't change it, because if you change it, they will remove you. So we have 3,673 villages arranged into 392 clusters that give rise to 30 ward development committees. We call it the people's government. Those are the people who decide what is going to be done. So once that is decided and comes to me, I am not at liberty to change it. So if you need to explain to them. So Makueni has a governance structure that will not allow you, that I invented. I just found a system, we have just improved it. If it's public participation, we have improved the public participation. If it matters health, we have just improved it. And I mentioned that we were first to pilot UHC, we were first to pilot FIF even before it became law. So we have a system of governance that you cannot play around with. So the people of Makueni don't pray. They interview their leaders. And if you don't comply, they will deal with you perpendicularly. So, so we don't sit pretty. Dr. Gibson is here. Where's Dr. Gibson? If you want, you can ask him. He's from Makueni. These are the people who question me. And they don't question me as if they're my friends. They question me, and I make sure that then I can return. We do feedback. So I create ward policies, ward profiles, and respond to them in terms of how we are accounted for. That is the reason we are the only county in Kenya today that has a clean audit report. It's because of that process. Thank you.
Thank you. So, Governor, now I want to wrap up this discussion, and I'm going to ask each of our panelists to give a parting shot. We'll say, like, can we do it in 90 seconds? Yes.
Okay, parting shot. From listening to, first of all, from my own experience and listening to the conversations, I think my parting shot is this, that we as two different groups that are essential in determining health outcomes for a large proportion of our population, we speak different languages, but that conversation can be broached when we come off from where we are as far as the language we use every day to a language we both can understand. And once we have that going, then the governance system will understand what the surgeons are asking for, and the surgeons will understand what the government has to deal with to cater for them. That's my parting shot.
Absolutely, absolutely. And then Dr. Omari?
Yeah, my parting shot will be minimally invasive surgery must be a priority in all our hospitals. We really must take minimally invasive surgery, that is laparoscopy and endoscopy, to be part and parcel of what we do every day. And if it means engaging the governing system, your governments, your administrations in your hospitals, you have to aggressively intervene in that sector, because we cannot stay behind and let minimally invasive surgery not develop in our hospitals. So, and in terms of teaching, because I think most of us also come from teaching and referral hospitals, this must be incorporated in the everyday teaching of surgery. And now, in the current day, with the advent of Proximie, we can all be communicating. I mean, everyone, someone in Kisumu, from Makueni, and all the way here in Mombasa. I think yesterday we were doing a case here from Coast General, and it was beamed directly from here. The other time we beamed it all the way to Homa Bay. So we should all be able to communicate, learn, teach, and even mentor. And it's all at different levels, right from the student level to even those who are experienced, to learn from even those who are experts. That would be my parting shot.
Okay, thank you. Makofi kwake. Dr. Bita?
For me, I think the data needs to reach the governance structures. If you look at one system that has worked in the country is the NPDSR, and you even had Governor Mtula sitting in an NPDSR. Yeah? And how it works is that the information is passed from one level to the other one, from the dispensary to the health center, it goes all the way. So the Surgical Society has been thinking about how to have surgical data shared in terms of pathology, gaps that are there, equipment that is needed, and that is what we need to raise and share out. We cannot go and sit on a table without numbers, yes. And the last part is surgeons, you just have to be part of that governance structure. You need to, I'm not asking you to run for governors, tutakula pesa yenyu tutamaliza. I'm asking you to take certain levels in these structures. Let's not just sit back and say we're just good at our gadgets and everything. We need to be all the way up. Thank you.
Thank you. Makofi kwake. So Governor, before I ask you your parting shot, I would like to ask Professor Odula to Professor Jaoko. This is a proper ambush because you are here. And we've just been talking about laparoscopy, minimal access surgery. Bita has given us numbers, statistics of how endoscopy and laparoscopy services would work. And you are, as the head of BB TAP, could you give a parting shot, having listened to this discussion, what you think the interface would be between what we do and what you do in terms of making these things become a reality? And I apologize in advance for the ambush.
Okay. No, thank you. I think this has been a very interesting discussion and a lot of eye-opening. And a lot of the issues that we deal with have actually also been raised. The issue of data, the issue of exactly what Doc was talking about, showing the evidence that this form of treatment, this form of intervention, as compared to this other form of intervention that is already in the health benefits and tariffs, is a better approach because of the savings. BTAP, the Health Benefits and Tariffs Advisory Panel, focuses on reducing cost of care so that more Kenyans can be able to access care. So if you produce those kind of data, there is no reason why that intervention would not be taken into account compared to the intervention that is already in the benefits package. So we'll be talking more about that. The problem we have is what the governor has actually said, we keep things to ourselves. We as surgeons know about all these things, but if you don't communicate that, then make those kind of decisions that require numbers. Looking for savings, what intervention for the ministry, and that is a very convincing case. So I think we'll be able to have more discussions about this, but we really need data. We need evidence generation because BTAP goes with what we call evidence-based decisions. So we need to look at all this evidence to bring a case. Thank you very much.
Thank you very much, and thank you for accepting the ambush. Karibu sana. So, Governor, we come back to you. Having listened to this, and I think we've had some good asks that have come up from this discussion. We want, as a society and as surgeons, to engage more with the Council of Governors and the governors in our different counties, and we want to foster these discussions. So, reflecting on what has been said, what are the wins you think we can quickly, chase after? What are the areas for county collaboration that you'd like to highlight? And finally, what would be your parting shot to this panel discussion that we've just had?
Thank you. Thank you for the time. I've said many things, but allow me to say that if I was not a lawyer and a politician, I would probably be preaching. So I want to preach to you, surgeons, and say that you do a good job. You do a good job. You are really appreciated. So you can clap for yourselves if nobody's clapping for you. For political purposes and governance, if you are not on the table, my friends, you are on the menu. So can the Surgical Society Group President find a way to find the Surgical Society on the table of discussions? These doors don't, it's only in the Bible where you are told to knock and the door shall be opened. Don't knock, break the door and sit on the table. So that some of the things that you are going through can find a footing on the table. I am a believer in training. That's why I've trained. So the training part, that's why I was very happy about this gentleman now. He came with students. Let's find a way that we can enhance the training. Lastly, I've mentioned this morning I was in a meeting of the MPDSR. Can we find an MPDSR lookalike platform for surgery? So that the data is talking about that, because now MPDSR has now become healthcare neonatal issues, but you don't have dashboards can be consumed. When you look at Tibabu, hakuna. We're discussing maternal, neonatal, etc., etc. So I plead with all of you that we find a footing into the council. Makueni will be first if we are going to drive the agenda. Your number one supporter and ambassador at the Council of Governors will be me. So let's start there, so that when you come out of here, we can have resolutions that we can take forward that would lead into some of these things. The MPDSR ended up with guidelines that we have now piloted and now appointed people who are now the champions of MPDSR. So don't reinvent the wheel. Find something that would, along the same lines, but now for surgeons, for the surgeons. And that's it. And then come to Makueni. I'll call you Mutua. I'll tell you what that means. Thank you.
Thank you. Makofi kwake. So as you've heard, I think, thank you. This has been a really good discussion. And actually one of the comments I'll make is, as a society, we've actually been working on a surgical services strategic plan. Because the question is this very question. And I think we will marry it to the dashboard. About this, we started with why surgeons in this room should care about politics. Mudoka is opening heads. The governor said we need to be more human and not wear scrubs and be out there so that people can see that. Secondly, you've had a real Mutula. So Surgical Society will carry this forward to help us advance this. We'll be looking at a structured proposal for a partnership watching across the country and the counties. This is the challenge we are posing as a Surgical Society of Kenya. And to all of you who participated, and to every person, we will close this part. So a round of applause for the panelists. Governor, before you run away, I think for one more thing, yes. Before you, so Governor, you can stay seated, but the surgeons will come down.
Wonderful. Mimi yangu haikuangi hiyo ya mvua mingi hivyo. Radi. Wonderful. We are going to transition very quickly to an additional session about technology. I know I want tea. You're overfed in conferences. So as Governor sits here, I want to welcome my panelists, as this button refuses to work. I will welcome Prof. Odula to the stage. I want to welcome Dr. Stanley Arugaru, Dr. Dea, Dr. Mayabi. But as the panelists come, I want us to reflect on something that has emerged from that and how surgeons shack matters politics, matters governance. Look at this plenary, and for those who are there at the AGM, remember how many we were at the AGM. Example number one. Example number two, with the MPDSR, during this conference, we were in an MPDSR with Dr. Mberua from the Council of Governors at 10 p.m. The gynecologists beat us at minimal access. I mean, they're the first, they pioneered a lot of the procedures that we were doing. You know, the first appendectomy was done by a gynae. Now, with MPDSR, they have gotten onto the political agenda in such a strong way. They have both county and national fighting over who is going to shepherd that process. And where are we? Surgeons, we just want to sit out of the boardroom and wait to complain that the packages are not good. Because everything, a lot of the time, we look at is from our perspective. And that's some of the things that we're going to be looking at. We're going into a technology session. I'm going to make it worth your time. And so if you haven't already done the Slido, you know, for many of us surgeons, we are very averse to technology. So I just have a question there. What emerging technology do you use on a regular basis? There's going to be a quiz at the end, and there's going to be a wonderful prize. So that message about the patient and their potassium can just wait a bit, but it's going to be a good opportunity that we will have to discuss. Technology, more often than not, is an enabler. An enabler meaning the technology doesn't necessarily come to replace you or your expertise. It comes to enable things to happen. Best example we have is M-Pesa. When M-Pesa came, everyone was like, ooh, how do you replace banking? And what do you mean I can send money with a message? But what ends up happening is an entire ecosystem is changed because someone believed enough. Now, if you look at the Africa CDC, they have now a digital transformation strategy running from 2026 to 2030 that guides governments on the pillars to look at to enable systems and technologies that facilitate development of healthcare. From the vantage point that I'm privileged to sit on, sitting both as a clinician administrator and in some of the teaching that we do, I dare say that where we are, not just in Kenya, but as a continent, we are at the point like when the internet was there in the early 2000s, when people were arguing and saying, why would I want to do online shopping when I can walk to the shop and buy what I need? And now, for those of us in urban settings where we can actually order online, that's where we are with minimal access surgery. And the counties are now realizing that, and they're supporting it as well as national government. So it is up to us as the clinicians to know that the technology is there. Platforms such as Proximie are coming up. I'm seeing most of us are at ChatGPT. Utilities. And just based on the fact that a majority of us are at ChatGPT, I know what they use the AI for. And we can do so much better. Who is on my panel? His Excellency, Governor Mutula Kilonzo has already spoken, County Governor of Makueni, first adopter of telesurgery, telepresence within Africa, essentially. But in Kenya has been a leading light in the adoption. Ready! Next, Professor Paul Odula, President Emeritus of the Surgical Society of Kenya. Here's what will emerge during the discussion. Even in Kenya, in discussion of using of this technology, it is the obstetricians who pioneered. But once we got a hold of it as surgeons, it was Professor Odula who now took up that trajectory. He was the chair of the surgical societies, the chair of the chairs of surgical societies, and he'll speak a bit about that. I'm going to talk with Dr. Stanley Aruyaru, a clinician, administrator, who also teaches and how he uses that technology in his practice. Dr. Cora Zondea, head of surgery at Jaramogi Oginga Odinga Teaching and Referral Hospital out in Kisumu. She's going to talk about that technology and how it worked for her as she was in her in-service training. And then Dr. Lance Mayabi, wellness advocate, laparoscopic, bariatric aficionado. If you give him the mic, he will talk about wellness before he talks about surgery. But he's going to talk about the implementation bit. A lot of this you might say, oh, that's possible in a public setting, but how does it work for you if you need to have this technology in a private setting? Next slide, please. So for Governor Mutula, I think we start off this discussion. Oh yeah. Rewind. Before Governor Mutula comes in, we have mentioned what Proximie is, and maybe we have not understood. So I'll ask the team to do a teaser, to run the teaser video, just to give an idea about what Proximie is as a technology. Go for it. Go back. So we'll just segue into Governor's discussion. So Governor, tell us about your decision to adopt this technology. And I know it started with the obstetricians and gynecologists. So you made that decision not as a clinician, but as someone who saw what the technology could do. Tell us about how that initial discussion occurred.
Thank you. I don't want to repeat myself because I had spoken about some of this technology. But when I got into office, I was very clear in my mind that we needed to accelerate healthcare and improve and use innovation. And part of it is as a result of what happened in COVID. COVID was a good example of how we can be efficient in terms of the work that we are doing. So when I was told about Proximity technology, that is not only a teaching tool for purposes of our students, but it will also be used for learning, and our theaters will become more visible. There are so many things that came to my mind from my own training and from my work in legal practice. I knew that first and foremost would have accountability. We would have accountability in the sense that we would have a depository of something that we can keep in case there was an issue. Two, in terms of work, I knew that obviously when people are being watched, something happens when they are being watched. And this I learned when I went to Japan. I was the drafter of the initial cybercrime law. And when I went to NEC Japan, they told me something very interesting. They said, we have so many cameras, but we also have dummy cameras. And I asked, so what is the point? They use cameras as a way of, we are just human beings, and we don't like being watched. But when we are watched, we are a little more careful. Papa Waroma, Senator Wetangula used to say, Wetangula now Speaker used to say, who watches the watchers? When we were speaking about Parliament. But then who watches the surgeons when they are doing their work? Who's watching the anesthetist when they are doing their work? Who's making sure that somebody is doing their job correctly? So part of it is that understanding that with this technology, we will not only achieve efficiency, but we will achieve accountability, because eventually the team that is working in Makueni, they will do their job. But when something goes wrong, the person who they will ask, who has no clue about what happens in theaters, is the governor. So I assume responsibility for the doctors, I assume responsibility for the teachers, I assume responsibility for anything. That's why I have bothered to get into the details. But I had the privilege of going to Geneva and seeing what they do in terms of training, in terms of their facilities. And I can tell you that we must leapfrog some of these technologies so that we can reach out to as many people as possible. We have such a huge population of underprivileged Kenyans, and we cannot leave some of this care to the people who have money. Even the person who is Mama Mboga should be able to get good care, because that person is a Kenyan and that person deserves health care, just like the person who is able to pay for it. So for me, it's an all-round thing. It's a 360 degrees. So I can see, and what I can see, you can see. So there's a word called ubiquitous. So for purposes of proximity, I become ubiquitous in terms of watching what is happening. I'm everywhere. So I'm seated in my office, and the person in the surgery knows that I can see what they're doing. Thank you.
Wonderful. And a round of applause for Governor. And so for Professor Odula, you were there from the beginning. You have seen the growth in the 2 years. What do you think this growth means for how we train? And you know that in the background now, there are MOUs that have been put in place. There's the MOU with the SAGES, with the American College of Surgeons. Started out this in Makueni, the hubs have increased. We just signed the MOU with Kenyatta National Hospital. Talk to us about how it means for the future of training in this country.
Well, thank you, Njihia. I must say, just after I took over the presidency of SSK, this 2024, that's when Dr. Shannon Shibata Germanos approached us and told us about Proximity. At that time, we didn't quite understand what she's talking about. It's only later that when she talked about Makueni and how they managed to bring the maternal mortality to virtually zero within a few years, then we realized that this is something we need to look into. And from then on, she said specifically she wants SSK to run with this story. And I can tell you, within 2 years, what was just in Makueni went to NSSC There are over 50 hubs within the region in 2 years which have Proximie installed. This is amazing, and we're still on the run. In fact, I think nearly half, 15 counties already have Proximie installed. Right now, here, Kenyatta National Hospital Finance signed in, and it's an issue of installing the 6 theaters, 8 theaters now. And I think it's going to play a key role, not just in training, but in-service, not just in in-service training, but later on, when surgeons to come back and do certain courses, they can still use Proximie to beam it to across other areas, and they can learn a bit more from that. I think the most recent thing we saw when, and like Dr. Mario's here, how he can do something has been seen in Homa Bay, and when in Sages, you could see Omari doing surgery here. So it is two-way. People feel that it's only cutting-edge surgery being down there. We're also doing cutting-edge stuff around here. We have the region, people ringing in from Rwanda, from Uganda, and seeing what we're doing, and they want to join in and see how best they can improve their practice. So the future of Proximie is not just telementary, but it's something which you can use to do case reviews. You can see how you did something, how many times you went over something before you made a decision to cut it or to clip, and be a bit more efficient in your movements. And this eventually will be a competence sign-off thing for trainees. So you can see, for example, Brian, a postgraduate student, doing a cholecystectomy. And you notice that it took over 2 hours and he really struggled. By the time you see his next cholecystectomy in a month or two, you can see there is actually a big improvement because you have all the previous case reviews. So it's not an issue of a logbook signing off. You just go to the video recordings, and that will make signing off very easy for postgraduate students in future. And not to mention also CPD, CME, will find Proximie very useful and as a tool to guide on our approaching or uploading these points. Thanks.
Wonderful. Thank you. I'll ask if the team, is the teaser ready? There are several things that Prof. Odula has spoken to. The concept of a digital community of practice. So one of the things we are looking at is how to join a digital community of practice. That's part of the reason there was the QR code to register which digital community of practice you'd be interested in, as a means to getting CPD points. Like, so my senior, Dr. Ndungu here, he has a digital community of practice for advanced GI surgery. And so when he is actually doing a gastrectomy, a laparoscopic gastrectomy, and you're interested in advanced GI, then you're able to join that live teaching session without having to go all the way to be in his OR. That forms something that we can do. Within the technology, we are also looking at how do we incorporate the DOPS, direct observation of procedures, or OSATs, objective structured assessment of tasks, so that as a trainee, asynchronously without my teacher, my supervisor, my mentor being physically with me, they have access to my videos and they can give that feedback. So much so then they would say, the next time you are having a case, let me know and I will join live. And we can see how to uncover or improve certain elements of that operative step. Is the teaser there or do I continue? It's ready. Okay. Join it up. Because I still see in the back of the room, people are still a bit confused. This technology, I am on Google. I don't even use ChatGPT.
Proximie has come in handy in not just Abington, but many other hospitals in this country. We already talking about 6, 7, 8 centers to use Proximie, not just to communicate with other colleagues across board, but also help in training residents. And through that effort, we're able to archive our data, and later on, you can retrieve it and see how best to improve your practice.
sites in many other counties. Our target is within a year we should have 20 other counties with Proximie installed.
So in terms of the setup, you actually have, in the ORs, you have a camera right perpendicular to your operating table, you have a room view, and then you have what would be the scope view. And now we have, if you go to the booth, you'll actually see there's a mobile unit that works with just an Android phone, which is something that now becomes mobile and you can use. And then the third thing you want to note is that with Kenya as a country is blessed with good connectivity so that it works by and large, even with a dedicated network, but it comes with the security, clinical and military grade security to ensure that, do you know that sharing images and videos on WhatsApp is technically illegal? Do you know that streaming cases on Zoom is also illegal? But those are discussions. You know, sometimes we can feign ignorance. Dr. Ruyaru, you wear that hat of clinician, administrator, you have residents to teach. Tell us about how this technology has helped you supervise your residents, as it were, and what your administrative hat now asks that technology to give that information. Tell us about the monitors and how the room view helps.
Thank you, Njihia. Before I start to make my remarks, I just want to ask the IT team if they have any of these to be in the background, the one that shows the room view and the various spots, so that when we speak, people don't get lost. The second bit is to pick from where you left on DOPS, directly observed procedural skills, assessment of residency, the OSAS and all that. When I was in training, the late mentor, I remember him coming to me and Lance and Kobe, but that day it was me and Kobe, and telling me, Stanley, you know, ideally I should just come and watch this video where you are dissecting the calots, and then I sign you off. And if that was happening now, I just keep remembering. And I want to say two things. First is one of the main areas you feel when you are a trainee is when you just want to fly, the faculty is clipping your wings. Because like, no, don't start before I come. So it becomes a constant challenge as you are finishing, and you just want to be able to be dependent before you are independent. Those you know. And the second bit is when you are left as second on call at night, this is the moment you are really happy because you won't wake up the consultant. They won't sneak in. You just tell them, hey, boss, I'm good. I will let you know. The issue is when you are good and you let me know, I will come and see a post-op patient. We operated, everything went well. But I can't quite tell, and that is the most important bit that I would have utilized to say, Njihia can independently practice this safely, and therefore I pass them on the DOP. So that becomes important for us to look at it by just asking, oh, you did an appendectomy at night, show me the Proximie recording. And then from the 360-degree view of the room, I can tell them, your shoulder is a little awkward. Don't lift your elbows unless you want to fly. You know the mantra. And then I can say, oh, you took quite some time here. How was your exposure? Why did you skip this step? So that becomes reinforcing so that you don't have to wait until you have all the case logs inside. The second bit is related to what we talk about in global surgery, the lack of access. And I think there was a discussion yesterday that the access at the moment now has become must. Kenyans are not struggling to reach the hospital. They are reaching the hospital within the period, but they don't meet the specialist. And I think that for me has been the revelation with the technology. When they meet the resident on call or the MO on call, we assume they have met the consultant, but no one is asking how long has it taken before the consultant arrives, because the consultant don't live in the hospital. So if you have a patient who comes with acute scrotum and you think, I have a 2-hour window to save a testicular torsion and do octopexy, the resident will be ready and we are waiting for the surgeon. And you and I know the anesthetist will never induce the patient until they have seen you because they have been bitten twice. So what we've seen is, in these emergencies, if I can tell the resident, start, because I know you, I have operated with you, prepare the patient, start, I am, as I look through, I am coming, then that serves two things. One, it cuts the turnaround time, so that the time to access to emergency care is not delayed because the senior boss has not come even when the frontline person was available. That's the first one. The second is the time to independent practice for the resident becomes very easy, because then as I am preparing to walk out, I can actually watch and say, oh, this one is exactly like the case we did at 4 p.m. Just make this maneuver, retract this plane, and we can annotate as you showed. Don't go here, leave that, that's tiger territory. Go here, we are good, I don't have to come. Now, I have described something we call wrapper. That is the room, so we have seen the 360 degree. This is where you are told to stand, which is not good. So we can see this is the 360 degree. And the importance of this for someone who is looking is that you are able to tell, this is my anesthetist. I keep saying of all the teams in Proximie, I'm the proper one in that world. The others are fancy. You've seen the gowns, disposable gowns, fancy stuff, but this is PCA Kikuyu, and this is my anesthetist. So I know anesthetist has not disappeared, and the scrub nurse is usually around here. So when I don't see them, I have a problem. And like Governor was saying, you have a 360-degree evaluation of what is happening before you go. But what I insist is this, because the technology has the port for you to feed the anesthesia monitor inside. So I can look at this in the room because the resident tells me, this is just re-exploration to just check and we are going to go. But when I am seeing a heart rate of 116, I know either the patient is not relaxed or the guys are bleeding and what they are telling me. So that gives me an opportunity for me to leave wherever I am and just walk. And all they realize is, oh, you are in the room, we didn't know you are coming. So that way kind of helps, because when the resident is stuck there, they are not sure when to quickly call for help because they have not been there. But you can add 1+1. You can see the anesthetist who is concentrating. You can see a patient heart rate that is rising. You don't have to wait for the resident or the anesthetist to say, no, Daktari, here you have to come. You just show up miraculously and like, oh, how did you predict this? Because you have been beaten in the past. Thank you very much.
No, thank you. A round of applause for Dr. Aruyaro. For many of us who did in-service training, go for a course, come back to your home hospital, and you're in that boundary of anxiety about how do I do the first case. Dr. Ndungu is here. The many times when I was a junior consultant, I would say, Doc, when do I book this case we do together? And now, I want to get Dr. Dea's perspective as someone who walked that journey as well, didn't have likely the same challenges that we had. So we didn't have technology when we were getting straight out of school. So Dr. Dea, how has it been for you to actually do in-service training as a specialist and be in that context of a digital community of practice?
Thank you, Ben. So for me, I would say that getting into the digital community of practice has provided for me a mentorship space, one that is accessible. I'm able to access every specialty at any given point, but it also allows peer accountability. Apart from that, we are able to discuss cases without the hierarchical nature of medicine and surgery. And so that makes it easy. In other terms, once you qualify as a surgeon, most of us, when we are training, we train at high volume centers, probably in Nairobi, where we have many of the surgeons. But majority of us end up being going to other centers that are isolated. So you have a surgeon that is posted to Siaya. He's the only surgeon there. They don't have anyone else to discuss cases with. And having joined this digital community of practice actually removes that isolation as a surgeon. While all this is important for me, it might not be very impactful if it doesn't translate to other areas, and that is the patient and even for the surgeons that I work with, and also for the residents that train under us. For the patient, how it becomes important is that when I have a case and I have asked my colleagues and my peers to dial in, we are able to discuss these cases together and make shared decisions. We are also able to anticipate complications and discuss ways in which we can correct them. What that means is that we have better outcomes for the patients. For the residents that train under us, we are able to look at these videos. So we do cases, we record them. When we are having the next case, we are able to look at these videos. And how that helps is that we are able to see certain areas that we need to make improvements on. And that, in a way, makes us have self-audits and self-improvement. So that has also improved the relationships between, me as someone who is being mentored, my mentors, and even the residents that train under me. So that would be what I would say is my experience.
So tell us, what do you, for a member of the Kenya Association of Women Surgeons, be sitting there and wondering, how does this work for me? What would your 2 or 3 words be for them?
Probably not 2 or 3. But what I would say is that being a female surgeon comes with certain challenges. And one of the things that the female surgeons in these rooms would say is that we suffer from imposter syndrome at some times. And usually doesn't mean that you are not good as compared to your peer who is a male. But usually it's just some self-doubt that women have. And even in the workplaces, sometimes you are questioned. What having this digital community of practice helps with is that you are always assured that you have someone behind you that reassures you, that tells you that you can do it, and we are able to look at this together as a team. So I think that's something that is very encouraging, and I would encourage all of us to embrace as part of technology.
Wonderful. A round of applause for Dr. Dea. So for Dr. Mayabi, I want you to weigh in. For example, you started the journey with Lap Mashinani and the initial challenges that were there in terms of how do you stream the content, what were the doubts that were there at the time, and then also you have had to champion the installation and the use of Proximie at a private facility. Tell us a bit about how bringing in the rest of the wider team has helped the patient safety and quality of care go up.
Okay, so I think I'll just go back to a story so people understand what laparoscopy Mashinani is. So this is an outfit that started around 2018. And just listening to the background, I think gynaes usually push things. So this was an outfit made by a group of gynecologists who their focus is endometriosis care in women in this country. And they needed a general surgeon, so I tended to just join them every month when they travel around the country offering free laparoscopic care to women with endometriosis. Then we'll have almost 3 monthly to 6 monthly cycles where we'll go and stay in a hospital in the rural areas and offer care for that time. But people will dial in at that point. And my biggest worry was, at that point, we're using Zoom and all those things. And as we talk about data protection and all, you really don't know who's seeing on the other end and whether there's privacy or not. So fast forward, I think 2 years ago, Professor Odula approaches me and tells me, we need to do a laser hemorrhoid course at the current hospital. And so I asked him one question. So you need us to beam to other people to see. And I already have these qualms within my head that for us in the private sector and in our hospital, it was quite a big challenge where we don't want to broadcast things and we don't know who's seeing it at the other end. And he tells me, don't worry, there's Proximie. I'm like, huh? Proximie? So anyway, so he assures me that it's military grade security and all. And we end up doing the workshop, and it was a success, and then we move on. So fast forward, Lap Mashinani comes to Corazon. So we are in Kisumu. We were there for a week, do some cholecystectomies and amongst other gynecological surgeries. We get to bond with Corazon. But my biggest issue is she's really good at what she does. She's And like you said, she's come for training but goes back and there's nothing to mentor. And I think now I go back, at that point we're already using just that experience and knowing that military grade, our superiors or our work was able to buy in, and that's how we're able to also push it down to Kisumu for Corazon, and I think also Helper. And I think that has been for me, just knowing that there's security within that, I can have privacy, I can actually review my cases for myself. No one else has access to that unless I give you access to it. Even within my institution, no one else can see it unless I give access to them. So that has been one, a very good, important tool. The next thing is, we're in the private sector, but we also run the COSEXA residency program, where I was the program director. And it's good. I think I saw my former resident here, Dr. James Karaoke. He can attest to that. And we will record the cases and sometimes annotate and go back. And I think we have a repository where we can always see how far we have grown. Even myself, and I know I've been done always, apart from what Stanley wants to look at the room and see the anesthetist and all, I think for me, as we are getting older, we have the shoulder pain, elbow pains, and all these pains. As we're getting older, but anyway, they're somewhat older than us. But anyway, for me, one thing that I've actually learned over time is, why did I struggle to get access one? Why am I having pain at the end of the day? And some of it was just your ergonomics. Why are we delaying? And sometimes it's a very critical step, and you find people on their phones, or you run a nurse. You know, usually say run away nurse. They ran away when everyone has settled, and you're asking for something, and it's taking such a long time. And for us, where in the private sector, where theater time is built per minute, so that's a cost I'm adding by waiting. Okay. So it has been enabled us to, as how we brought in now everyone to buy in, is because we'll sit down after a case, especially if it was a difficult case, whenever went through the standard time that we always have it, and ask ourselves, what were the issues in this case? So we look at the room view, we look at the top-down view and see how we placed our ports, we look inside and see whether there's maybe we're fogging too much or anything, and then just analyze and see how we make it efficient. And I think going forward, even just to put in like artificial intelligence and all that to help management be able to see what we are doing and advocate for the time that are being spent and in between cases, and now that is being utilized.
Wonderful. Yeah. Thank you. A round of applause for Dr. Mayavi. We're wrapping this up now. I'll just ask, we go from Dr. Dare that way. In 20, 30 seconds, what's the takeaway that you think people should know about this technology and the use case that you spoke to? Then we'll finish with Governor from his bird's eye view.
Yeah, thank you. So for me, just borrowing the word that Prof used, we are in the age of telementoring, and it's available to you at any point, whenever you need it, and therefore you should embrace it in order to develop yourself professionally. Thank you.
Ready?
Thank you, Jihi. I am reminded of the words of the Irish playwright George Bernard Shaw, who said, every profession is a conspiracy against the lay. And what was spoken by the previous panel is that as surgeons, we are in this recess that no one knows us. And therefore, every opportunity we get to speak our story in a way that is adding value and impacting the rest of the world becomes important. And I think we should look at the technology that we can adopt that would enhance that and take care of all the bottlenecks that we have. That is one parting shot. The second parting shot is an experience, an example given of most of the major marathons. If you look at the example of the Boston Marathon, and just Google from any of the gadgets that the surgeons have said they interact with, who are the winners of the top marathons? It will be Kenya, 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 Ethiopia. Kenya, 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 USA. Kenya, 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 Kenya. What that tells us is that Kenya is not short of talent. World over, we have world-beating talent. What we need is the converse. If you look for teams that are winning World Cups, Kenya is missing, because what we need is to bring systems and teams that can compete to enhance our talent, and that applies to surgeons as well. So if we can use this technology to elevate us as a team effort, then Kenya will keep conquering. Thank you.
Ready!
Just a parting shot. I think where we are graduating so many surgeons because of your series, instead of just a signature saying, I think is good.
Ready?
Just to usually live in recesses, and surgery in our life. And like we say, the purpose of living is being alive. And I think the only way to unlock that is to allow yourself to self-audit, to audit others, and self-improve. So that's what I'll just leave. And this platform that allows us to do all that.
Ready, Governor. Advocacy,
yes,
teaching
you.
And in-service.
Thank you. I speak about these things because it's not abstract. I've been threatened by your colleagues to be thrown out of theater when my son and daughter were being born. One of the relatives of Professor, it's called Carol Adula, asked me to sign some form. He said, now when we get into the room, you stand on the other side. I said, no, I'm going to stand on this side. When I attended a conference on maternal mortality in Nairobi about a month ago, a gentleman gave a very harrowing experience about his wife. What am I saying? That in the end of the day, the people who are getting into theaters, there's a person outside who needs some comfort. They need to be comfortable. That they can go and do whatever they want to do, and they will come back and they will pick their relative, etc., etc. And where things go wrong, there can be some element of evidence of what happened. So if you think about your patient and the person outside that room, it gives you a good inclination that you are dealing with an ecosystem of many people. You have a patient, but you have a husband like me who wants to sit in theater and freeze to death. And if there was a possibility that I could just sit in a room and not freeze in that theater like I did, or possibly they made it so cold so that I leave and I didn't. Then you can watch. But more importantly is we are all the same people. That person in Moyale, Garissa, Kakuma, Lunga, a place in Makueni called Kadhonzweni, Kitise, and all the villages. Everybody just wants the same thing. Everybody just wants what everybody wants. Good care. People are taken care of. Pwani ni Kenya, Makueni ni Kenya, Garissa ni Kenya, those things. And if we are going to achieve this, we will not achieve it by just doing the way things have been done previously. We have to leapfrog everything, teach, learn, so that we have a Professor Odula in Garissa. We have Dr. Bita in Lunga, the most far-flung place, or an island called Wasini, out there at the tail end of the country. But even then, when I went to Geneva, I learned something, and I want to share it with you. We have the opposite. They do a lot of training on mannequins. For example, on matters bones. I hope I'm using the right terms. They would like to come to Kenya and see how you do it, because their training, half of it is done on robotics. That's what I learned. And you people are dealing with real human beings on a daily basis. I was pleasantly surprised. I want to explain to you that before they did, I was there when they were planning to do a head surgery. So they have something like a robot, not a real human being, with a brain that bleeds, and they do a trial run first. So everybody in the room does a trial run before they get into surgery. in Kenya, you guys get into the thing and say, Kaende. Allow me to use this example. During the cold season, a lot of the pilots flying into Jomo Kenyatta don't want to dare because there's no visibility. So they hover around and wait for a Kenya Airways plane. Kenya Airways pilots wanasema bwana, we're going home bwana. Angusha ndege. So it's what you people are doing. So can we use that experience so that the other people can see what Kenya pilots are doing for Jomo Kenyatta? Kaende, asante.
Round of applause. So I won't add anything to the parting shots of our wonderful panelists. As I hand over to the recognition of the next step for our amicus curiae, let us have Dr. Mayabi, Professor Odula, Dr. Ruyaru, and Dr. Dea walk off the platform as we clap for them and acknowledge that. Back to President.
Thank you. Yes, this has been a fantastic morning. Thank you for the discussions. I think my job is to wrap up this session, so Governor, I'll invite you to come closer. Amicus. Chirugai. Actually, we have a Latin term ourselves, Amicus Chirugai. So we are grateful that you took the time to come and spend with us this morning. And we've had really good discussions, very insightful discussions on surgery, expanding access, provision of care, policy, all of these things. Now we've just finished looking at telesurgery and telepresence and how we can do that to improve what we do. So on behalf of the Surgical Society of Kenya, we would like to recognize the efforts you have made personally towards improving surgical care in your county and by default other counties. And so we would like to, on behalf of the society, we will be appointing you an honorary Surgical Society of Kenya champion. So, karibu sana. So Dr. Badawi is here. Dr. Bita, let me follow some protocol because he's my successor. Where is Dr. Mbabu? Dr. Mbabu, are you here? Please come to the front. So I'm just inviting the members of the Executive Council. SG, please come up. So this is on behalf of the Surgical Society of Kenya. We would like to officially appoint you honorary Surgical Society of Kenya champion. I think that's what it says, eh? Yes, I'm giving the correct one. Karen, this photo is not balanced, gents. Yes. So makofi kwake. And then for honoring us with your presence, we have one more award. And I'll invite Prof. Odula. Where is Prof? Yes, Dr. Mwatha. You know, you should come up here because he's your right-hand person.
Absolutely.
Here.
Right wing. Right
Dr. Musila?
Is he here?
He's here.
Oh,
Yes.
Gibson.
Yes. Because this is for Makueni, Ombati, and Mudoka. Where is Mudoka? So this is on behalf of Surgical Society of Kenya, and we want to thank you for joining us. So please come, please come.
Come to the picture.
Yeah. No, Caribbean.
Very good.
Tall people. You guys are tall, eh? Karen can't be seen now. Okay.
Thank you. Thank you very much.
Okay.
Very good.
Yes, makofi kwake. So because of the work Proximi has done, so before you all go down the stage, invite Shannon, Simon to please come up. And then we'll have the rest of council please join. Where is any council members who are here? Please be coming up. you can tell we are doing photos by now. I've transitioned us to some photo session. Okay, so one more photo. Okay, one more photo. Okay, so Governor, one more photo.
Oh.
Everybody else. So we're going to move forward a little bit and maybe go down here. We are going to do a group photo. So all members, please come to the front. Oh.
Becomes easier.
Mr. Governor, sit on this one.
Oh.
Yes. Odula? Yes. Shannon? Karen? Where is Professor Jaoko? Where is Professor Jaoko, I see you there. Dr. Ndungu. Where is Prof. Jaoko? We have saved a seat for you here. There should be no one in the audience. Johnny, why am I seeing you? Zara, there should be no one in the audience. Dr. Ndungu. Please, there should be no one in the audience. We are doing a group photo. Okay.
Dr. Dea.
Hi. Where is Njihia and the Radi Manenos? Okay, Sergeant's power. Power. Semeni kitu. Everybody say Surgical Society of Kenya.
Surgical Society of Kenya. Sergeant's power. Power. Sergeant's power.
Power.
Very good.
Asante sana.
Thank you.
So thank you, Governor.
Thank you, boss.
Yes. So thank you all.
Thank you, bro.
Yes. So we will have a short break, 10 minutes, and then we resume. So we go back to the...
Mimi nilitaka kuweka weka quiz. Na sidhani tutapata time nyingine. Weka quiz. Connect. Ama tusiweke sahi. We won't be given the mic back. People are hungry. They'll eat up. I'm like, they'll eat in 1 hour. But it's no, I promised them there'll be something. And this is another man. So, I see you.
Have a secretariat that was taking notes. Maybe sign.
Sounds like there's a difference too.
Silence power. Government.
Let me